Bismillahirrahmanirrahim. My name is Mohammad Khalid and my moderator is Dr. GM. Today we will discuss specific infection of genitourinary tract. Today we will discuss chronic pyelonephritis, emphysematous pyelonephritis, xanthogranulomatous pyelonephritis, Fournier gangrene. Acute pyelonephritis. Acute pyelonephritis is defined as inflammation of kidney, renal, pelvis, and its diagnosis is usually made clinically. Clinical presentation. Patient usually presented with fever with chills, flank pain, nausea, vomiting, bacteriuria, pyuria, elevated white blood cell count. Causes vesicouteric reflex, renal stone, urinary tract, catheterization, pregnancy, neurogenic bladder, diabetes mellitus. In this picture, infection ascends through urethra into the bladder, deranged vesicouteric reflex that lead to reflex back urine into the kidney causes infection. Risk factor for the acute complicated pyelonephritis. Age infants, elderly, age greater than 60 years of age, anatomical or functional abnormality, polycystic kidney disease, horseshoe kidney, double ureter, uterocele, vesicouteric reflex, foreign body, urinary or nephrostomy catheter, calculus, immunosuppression state, diabetes mellitus, sickle cell anemia, transplantation, malignancy, chemoradiation, HIV infection, or use of corticosteroid. Male sex, anatomical abnormalities, prostate obstruction, obstructed factors, foreign body, calculi, bladder neck obstruction, posterior urethral valve, benign prostatic hypertrophy, neurogenic bladder, pregnancy, malacesia में inappropriate use of antibiotic resistant organism or instrumentations. Causative organism, E. coli. E. coli is the most common cause that causes acute pyelonephritis, Klebsiella, Protease, Enterobacter, Pseudomonas, Serratia, or Streptococcus. As previously discussed by Dr. Yumna in detail about E. coli mechanism of action, how it's work. This is a scenario. A 32-year-old male presented to ER1 with chief complaint of right flank pain, fever with chills, nausea, history of perurethral catheterization 3 weeks back, fever 102. On examination, right flank tenderness. How we can proceed in ER1?
So we will change the catheter and acute pyelonephritis. History, examination, vitals, ultrasound, and start antibiotics.
pyelonephritis मतलब इन्फेक्शन एक्टिव होता है चून में सप्लाई डाउन होता है वहां पे जब इन्फेक्शन होता है जितना ब्लड सप्लाई ज्यादा होगा जितना सेप्सिस के कारण या और इन्फेक्शन के कारण ज्यादा होगा रेनो पे भी ब्लड सप्लाई करनी ऑलमोस्ट 20-40% के ब्लड देते हैं यही है यस अगर है ना मुझे जो ओपन करके इनको तो सारे ब्लड काउंट्स जो है दे आर मल्टीपल टाइम्स साउंडेड बाय ठीक है तो ब्लड सप्लाई ज्यादा होगी आर्टिफिशियल एरिया ज्यादा होगा उतना और एलिमेंट सेप्सिस उतना ही सेप्टिक एलिमेंट्स जो है वो ब्लड में इधर होंगे Even or they can have benefits with see the practice के directly association of the staff को severe होता है इसी वजह से practice process range to be severe if I need to use first वो priority है कि जब patient आएगा वो suspect हुआ कि हमारे practice है you have to manage like a shop अरे उसका practice उसको ठीक होगा लेकिन अगर बाकी टाइम पे उसको नहीं है तो practice acute pulmonary ionosis story associated with sepsis. It's sharp line condition. It's another
Investigations. First of all, we do CBC, and CBC we see the TLC count raised as the acute infection. After that, we will do urine DR, as the urine DR is a rapid diagnostic test. Appearance of white blood cells, test for nitrite and leukocyte esterase. We will also do culture after 48 hours. Culture result mostly E. coli is found. Ultrasound. This is the ultrasound ultrasound of acute pyelonephritic kidney. Right kidney is normal kidney, while left kidney is showing enlarged inflamed kidney with dilatation of calyces, and this showing acute pyelonephritis. CT scan. We after ultrasound we will do CT scan. CT scan. This is the right kidney showing enlarged kidney with attenuated parenchyma, compressed.
डॉक्टर फहद ये कौन सा सीटी स्कैन है विदाउट कंट्रास्ट है श्योर परेशान नहीं हो ठीक से देख के बताओ
बॉबल में फ्लूइड है सर कंट्रास्ट
कौन कौन सा कंट्रास्ट है और कौन सा फेज है ये
सर आर्टीरियल फेज
इस पेज पे आपको ये पता होना चाहिए ना कि सीटी स्कैन कौन से पेज की फिल्म लगी हुई है और फाइंडिंग्स क्या हैं और फाइंडिंग्स पूछूंगा तो और कंफ्यूज हो जाओगे डॉक्टर कुलरेज
सर आईवीपी है सिटी
देखो कंट्रास्ट जो है वो हाईलाइट कर रहा है पेरेन्काइमा को ना किडनीज के पेरेन्काइमा को लेकिन एआरटा इतना ब्राइटली जो है एलिमिनेट नहीं हो रहा आईवीसी में भी कंट्रास्ट है एआरटा में भी अभी रेजिडुअल कंट्रास्ट है ठीक है यूजुअली इसको पोर्टोवेनस या जो है वो आर्टेरियोवेनस फेज कहते हैं और इसी में ही जो है वो इन्हांसमेंट है या हाइपोटेंस एरियाज हैं या क्या तो वो हाईलाइट हो रहे हैं यही जो है वो फाइंडिंग्स हैं जो इसमें पता चल रही हैं ये पुअरली परफ्यूज्ड जो है वो एरिया है जो हाईलाइट हो रही है दैट इज एरिया ऑफ इन्फेक्शन मेग स्कैन पे ये कैसे दिखेगा न्यूक्लियर स्कैन पे कैसे दिखेगा ये
किस
डॉक्टर श्रीजान
So in nuclear scan, there will be a decreased isotope seen in the area of right kidney and at the region of
यहाँ पे पाइलोनेफ्राइटिस है किडनी में फोकल पाइलोनेफ्राइटिस वो कैसे दिखेगा मेग स्कैन पे या डीएमएसए स्कैन पे कैसे दिखेगा
scarring आएगा
स्कारिंग आएगी वो कोल्ड एरिया आएगी वहाँ पे जो है वो कंट्रास्ट नहीं जाएगा
This is the picture showing acute pyelonephritis in a single picture, how the infection ascend or other descending infection due to septicemia or infective endocarditis. Risk factors, female already discussed. Cause, most common cause E. coli. Management. Patient usually present with signs and symptoms of acute pyelonephritis, fever, flank pain, pyuria, leukocyte, nausea, vomiting, or sepsis. If no sepsis, then we do urine analysis, urine culture, ultrasonography, outpatient treatment, oral therapy for 7 to 14 days. We give antibiotics, fluoroquine, aminopenicillin, cephalosporin, trimethoprim, sulfametazole, only if susceptibility of pathogen is confirmed. If patient improve within 72 hours, then we will continue oral therapy, urine culture 4 days on and 10 days of antibiotic therapy. If there is a urological elevation, then it's needed to be ruled out. If no improvement occur within 72 hours, then we go hospitalize outpatient, review culture and sensitivity, urological evaluation for complicating factor, drain obstruction or abscess. If patient presented with sepsis, then we go for urine analysis, urine blood culture, ultrasonography, inpatient treatment. Start parenteral antibiotics 1 to 3 days. We will start fluoroquine, aminopenicillin, plus beta lactamase inhibitor, cephalosporin third generation aminoglycosides. If improvement occur, we will follow the plan to switch on the oral therapy. If no improvement occur, then we will go hospitalize the patient and review the culture. Chronic pyelonephritis.
हमारे पास कोई गौर करता है, हमारे पास जो पायलोनेफ्राइटिस के या पायोनेफ्रोसिस के पेशेंट्स होते हैं उनका एंटीबायोग्राम में सही होता है सेम जो यहाँ पे गाइडलाइन में? डॉक्टर नजम,
Can you repeat the question?
एंटीबायोग्राम जो अभी यहाँ पे गाइडलाइन में है कि पायलोनेफ्राइटिस है, थर्ड जनरेशन सेफलोस्पोरिन देंगे, फ्लोरोक्विनोलोन देंगे, अमाइनोपेनिसिलिन देंगे। हमारे पास जो कल्चर्स आते हैं इन्फेक्शन इन किडनी, पायलोनेफ्राइटिस, पायोनेफ्रोसिस में, ये एंटीबायोग्राम में ये सेम ही है हमारे पास?
No, sir. We actually find quite a lot of resistance to most of these. In fact, there's no sensitivity to Cipro mostly seen.
डॉक्टर हसन, कौन सी एंटीबायोटिक्स जो है वो प्रेफरेबल होंगी यहाँ पे पायलोनेफ्राइटिस में या यूटीआई में?
So here we usually wait for the cultures. Empirically, we give terrosin. Otherwise, the antibiogram just mentioned here, we find resistance in our.
जो सेंसिटिविटी पॉजिटिव है, जिन एंटीबायोटिक्स पे सेंसिटिविटी है, उनमें से कौन सी सिलेक्ट करोगे?
So we'll start with cephalosporins or fluoroquinolones or cephalosporins, sir.
फ्लोरोक्विनोलोन्स वाई? कौन सी एंटीबायोटिक यूरिन में सिक्रेट होती हैं?
So fluoroquinolones, nitropyrrolidine भी होती.
और ये चीज पता होनी चाहिए ना, आपको एंटीबायोटिक डिसाइड करनी है तो आपको पैरामीटर्स पता हो कि कौन से एंटीबायोटिक्स जो हैं वो बेस्ट रहेंगे यूरिनरी ट्रैक्ट के लिए। ऐसी एंटीबायोटिक जिसकी पेनिट्रेशन किडनी में अच्छी हो, यूरेट्रिक और ब्लैडर वॉल में अच्छी हो और यूरिन में सीक्रेट होती हो। यूजुअली हम कहते हैं सॉफ्ट टिश्यू डेंसिटी जो है वो जिस एंटीबायोटिक की अच्छी हो, ठीक है। ब्लड सेप्सिस को ट्रीट करने के लिए अलग होता है, लेकिन सॉफ्ट टिश्यू पेनिट्रेशन अच्छी होनी चाहिए व्हेन देयर इज एन ऑर्गन लाइक ब्लैडर, यूरेटर और किडनी इन्फेक्टेड। और अगर उसकी सीक्रेशंस में अगर एंटीबायोटिक जो है वो सीक्रेट होती है, दैट विल बी फेवरेबल। तो इस चीज को पढ़ना है ताकि डिसाइड कर सको कौन सी एंटीबायोटिक जो है वो आउट ऑफ दैट एंटीबायोग्राम जो है वो सूटेबल होगी या बेस्ट होगी।
Chronic pyelonephritis. Chronic inflammation of renal tubules, interstitium with scarring and deformity of renal calyx and pelvis. Occur due to recurrent attacks of inflammation and scarring. It's the most common cause of end-stage renal disease. This is the picture showing normal kidney while the left pyelonephrotic kidney. Infection ascends into the kidney, inflammation of calyces that lead to scarring at the end, pus formation. Types based on the causes, two types: chronic obstructive pyelonephritis, refluxing nephropathy, chronic refluxing associated pyelonephritis. Chronic obstructed pyelonephritis, obstruction to the flow of urine at different level predisposes the kidney to infection. Recurrent episodes of such obstruction and infection result in the renal damage and scarring. Rarely recurrent attack of acute pyelonephritis can lead to renal damage. It can be bilateral has with congenital abnormalities of urethra, posterior urethral wall in infants. It can be unilateral has with calculi or tumors. Refluxing nephropathy, it's the most common cause of chronic pyelonephritis, result from the superimposition of UTI on congenital vesico-uteric reflex. Reflex of urine up into the ureter during maturation manifests in the early childhood. Reflexing incidence of reflexing occur to the sex is equal in the infancy, but after infancy, both pyelonephrotic scarring and reflex are far more common in female. Infection is likely cause of progressive scarring in female. This is the picture chronic pyelonephritis showing bladder as there is septic urine, deranged vesico-uteric valves. The urine reflects back into the kidney that causes thin cortex, scarring due to infection or dilatation of calyxes. Presentation. Sometimes patients are asymptomatic. Patient may present it with fever, flank pain, usually presented with chronic renal failure or symptoms of hypertension. Frequency of maturation and dysuria. Management. Antibiotic therapy, penicillin, cephalosporin, group of drugs, any obstruction that should be released, analgesic, surgical correction of VUR, uncertain role control of infection appear to prevent progressive scarring. Next, emphysematous pyelonephritis is defined as necrotizing infection characterized by gas within the renal parenchyma or perinephric tissue. Contributing factors, most common female diabetes mellitus, 95% occur due to diabetes, renal failure, immunosuppression, obstructed upper tract, polycystic kidney. Pathogenesis as E. coli, Klebsiella, or protease are the gram-negative facultative anaerobic organism which ferment glucose and lactate to carbon dioxide, causing necrotizing infection in an appropriate tissue environment. Presentation. Patient usually presented with fever, nausea, vomiting, flank pain, loss of appetite. Causative organism. E. coli is the most common cause, leading to 66%. Klebsiella pneumoniae, protease, Pseudomonas streptococcus B. Investigation. We will do mostly X-ray, KUB, ultrasound, or CT scan. We will in X-ray we will see gases, or ultrasound also air in the kidney. CT scan is the most sensitive, detecting the presence of air in the renal parenchyma. This is the CT scan left kidney showing the black air in the kidney, showing emphysematous pyelonephritis. मैनेजमेंट
क्या क्या सीटी स्कैन पे जो है वो फाइंडिंग्स होंगी एम्फाइसेमेटस पायलोनेफ्राइटिस की डॉक्टर रेखा?
Sir, there will be air in the kidney, thin cortex or thickened parenchyma, or there will be a dilated pelvic calyceal system.
सिटी स्कैन आपके हाथ में हो, जैसे ये पिक्चर है, आप इससे क्या डायग्नोस करना चाहेंगी, क्या देखना चाहेंगी कि इसके लिए फिर डिसीजन भी बना सकें? स्टेज देखेंगी, टाइप वगैरह। इस स्कैन में जो है वो गैस कहाँ पर है? कितने टाइप्स हैं एम्फाइसेमेटस पाइलोनेफ्राइटिस के? डॉक्टर नादिया, टाइप्स पता है एम्फाइसेमेटस पाइलोनेफ्राइटिस के? कोई वॉलंटियर एम्फाइसेमेटस पाइलोनेफ्राइटिस के टाइप्स?
There are 4 grades. It was given by Wang and Singh. Like grade 1 is a gas within the collecting system. Grade 2 is gas in the parenchyma, and there is grade 3, A and B, where there is gas up to the perinephric fat and pararenal space. And grade 4 is emphysematous pyelonephritis in solitary kidney, or if emphysematous pyelonephritis is present in both the kidneys in a patient. That's grade 4.
गुड। सीटी स्कैन जब हाथ में होता है तो इन चीज़ों को देखना होता है कि इनमें से कौन सा टाइप है, और उसके हिसाब से प्रोग्नोसिस होगा और उसके हिसाब से ट्रीटमेंट होगा।
Management, treat the underlying cause, good control of blood sugar, relief of urinary tract obstruction, fluid restriction, parenteral antibiotics for 3 to 4 weeks. Prognostic factor, high serum creatinine level greater than 1.4, low platelets less than 60,000, presence of renal or perirenal fluid, bubbly loculated gas in the collecting system. Next we will discuss.
ये प्रीवियस स्लाइड पे ये प्रोग्नोस्टिक फैक्टर्स में जो ये सारे पुअर प्रोग्नोस्टिक फैक्टर्स हैं, प्लेटलेट्स काउंट कम हो रहा हो या पेरिनेफ्रिक जो है वो कलेक्शन वगैरह हो रही हो साथ में, लेकिन ये जो बबलिंग लोक्यूलेटेड गैस इन कलेक्टिंग सिस्टम में ये नहीं है। गैस इन पेरेन्काइमा, पेरेन्काइमल रिस्ट्रिक्शन होगी, नेक्रोटाइजिंग इन्फेक्शन है पेरेन्काइमा का, देन देयर विल बी पुअर प्रोग्नोसिस। कलेक्टिंग सिस्टम में अगर गैस है और पेरेन्काइमा इज ओके, यू विल ड्रेन इट, यू विल मैनेज इट एंड इट कैन इम्प्रूव, उसका प्रोग्नोसिस इतना बुरा नहीं है। लेकिन अगर पेरेन्काइमल डिस्ट्रक्शन है, पेरिनेफ्रिक कलेक्शन के साथ है, तो ऐसे प्रोग्नोसिस और पुअर होता जाएगा। दैट किडनी विल हैव टू सैक्रिफाइस। यस डॉक्टर पिला।
अच्छा, एक इंस्टीट्यूट का एक जो है ना वो सीन बन जाता है कि भाई कि मतलब इस पर्टिकुलर सिनारियो के अंदर हमने ये करना है। तो एम्फाइसेमेटस पाइलोनेफ्राइटिस के लिए एक हमारा सिनारियो ये है कि जनाब ये तो गुर्दा निकलेगा, ठीक है ना, मगर व्हाट हैज टू बी केप्ट इन माइंड इज दैट दीज patients of emphysematous pyelonephritis are mostly old age patients, diabetics who are already very much compromised nutritionally, immunologically, and they're not in a state of getting operated upon. So these are the patients on which you have to sit upon and think about when to operate and when not to operate. So they require resuscitation, they require drainage, and they require you to wait for the patient to get in a better condition so that you can operate on him in whatever the condition. Just recently, I was given a case to operate upon, I think 3 weeks back. And I was told that this lady had emphysematous pyelonephritis, and we have drained the pus, and now the creatinine is normal, and this is the window period, and we have to operate on her. And the condition of the patient was as such that she couldn't even get out of the bed by herself. So one has to decide when to operate and when not to operate, and sometimes when not to operate is a very big decision rather than when to operate one. So these are the patients who are very much compromised nutritionally and immunologically given their age and comorbids. So an emphysematous pyelonephritis diagnosis does not automatically qualify someone for surgery or for a nephrectomy. And what has happened in the preceding 3 weeks for that patient is that we built her up nutritionally. We repeated the MAC. Now the status is that kidney which we were adamant upon taking out is now a 40% kidney with a single stone in the upper calyx. So if you give time to your patient, you will end up saving lives and you will end up saving the kidney as well.
Quite right. I can be with you, but the experience tells us the other side of the story. And if you get hold of your patient and try to follow the same patient for the next maybe 1 year or 2 years, maybe you will find another view of whatever you are saying. It's not an assumption. It is something which is through experience. Then 90% of the cases, once they come up with emphysematous pyelonephritis, 90% of the cases they recur, and maybe 1 year or 2 year or maybe 6 months down the line, these kidneys have to be taken out. So it's better to do earlier than to wait for something to happen when, as you have said, the patient is not in a condition to be operated upon. The problem is you want to manage these patients nutritionally. These patients are already diabetics, most of them, almost 100% of them are diabetics. Now, with diabetes, what happens to the leukocytes? Their movement is slowed down because of glycosylation. When the movement of leukocytes is slowed down, the whole inflammatory process is actually not towards the positive side, it's towards the negative side. Now, what I'm saying is not out of my experience or my assumptions, it's out of a lot of people's experiences. So maybe you are right. I'm giving you the concession of observation, but try to observe the same patient that you have been observing for the past few weeks.
Xanthogranulomatous pyelonephritis is severe inflammation, necrosis obliterating the renal parenchyma characterized by a foamy lipid-laden histiocyte. Form a chronic bacterial infection. Affected kidneys are
Just a passing, sorry, just a
Yes.
passing remark. I have seen many of the cases when there is a gas in the system. We try to put in tubes so that we can take out the gas. You see, it's not the gas. It's actually the gas producing organism. You can't take out those organisms through the tube.
is a form of chronic bacterial infection. Affected kidney is always hydronephrotic and obstructed, mostly unilateral. This is the picture showing black necrotizing tissue surrounded by pale yellow foamy lipid-laden histiocytes. Factors: unitract obstruction, infection, nephrolithiasis.
Can you diagnose xanthoclematis pyelonephritis by having a urinary specimen? That was a question asked in FRCS. And if yes, what comes into the urine of these patients? So anybody from the audience, you can ask anybody.
Yes, Dr. Kamal.
Yeah. And these are known as foamy macrophages.
Foamy macrophages.
और भी points होंगी इसके favor में, if you can tell. And why we are diagnosing an histopathology?
Sir, it is mostly due to the obstruction. Secondly, to the xanthogranomatous is a result of the obstruction. Protein in, as well in the urine DR, but the diagnostic will be the foamy macrophages for the xantho.
See, chronic inflammation will be along with the granulomatous findings. और main important चीज है कि xanthogranulomatous pyelonephritis is mostly because of polymicrobial infections, not a single infection. Multiple bacterial and aerobic, anaerobic can be there, and multiple infections are the cause of xanthogranulomatous pyelonephritis. And this is somewhat tumor-like findings on radiology. That's why it's difficult to diagnose on CT scan, even contrast CT scan. It will behave like tumor. That's why sometimes we need biopsy in this case.
Factors: unitract obstruction, infection, nephrolithiasis, diabetes, immunosuppression. Presentation, usually patient presented a flank pain, fever, chill, persistent bacteriuria, history of urolithiasis, palpable mass oftenly. Dr. GM discussed that maybe we feel that it's a tumor, renal cell carcinoma. It's comments in differential diagnosis. Causative organism, E. coli and protease are most commonly cultured from the urine. However, 1/3 of the patient having low growth in the urine. Investigations in urine dia, leukocyte, bacteria and protein. Also, Dr. Asad Saab discussed that foamy macrophage, you will see blood CP anemia. Ultrasound, in ultrasound, the kidney shows the enlarged kidney with multiple hypoic masses, irregular thin parenchyma or dilated collecting system. CTKUP, most reliable, large heterogeneous non-enhancing uniform mass. This is Pierre sign is in the CT scan. They show xanthogranulomatous. Management patient, we will do partial nephrectomy with excision of focal disease. If it's diffuse infection,
Remember, this is heminephrectomy. Partial nephrectomy will be used for the tumors. Heminephrectomy, then removal of the part which is non-functioning and infected.
if the infection is diffusely, then we will do nephrectomy. Fournier gangrenous, named after the French venereologist Jean-Alfred Fournier, 1883. Fournier gangrene is defined as polymicrobial necrotizing fasciitis of the perirenal, perianal or genital areas. This is the picture showing black necrotizing tissue that involved in the scrotum area. Risk factor: diabetes mellitus, alcoholism, malignancies, cirrhosis of liver, chronic steroid use, HIV infection, malnutrition, morbid obesity. Etiology and risk factor: initially described as idiopathic, now in the more than 75% of cases, initiating cause is known. Necrotizing process commonly originates from the infection in the anorectal, urogenital tract or skin of genitalia. Etiology: anorectal cause. Infection in the perirenal glands, manifestation of colorectal injury, malignancy or diverticulitis. Urogenital causes: infection in the bulbourethral glands, urethral injury, iatrogenic injury or lower urinary tract infection. Dermatological causes: hidradenitis suppurativa, ulceration from the scrotal pressure, trauma to the scrotum or perineum. Other less common causes: consequences of bone marrow malignancy, SLE, Crohn's disease. Causative bacteria, polymicrobial infection, minimum of 4 isolated per case. Most common aerobic E. coli, most common anaerobic bacteroids. Other streptococcus, staphylococcus, MRSA, Klebsiella, Pseudomonas, Protease, Clostridium. This is the basically mechanism of spread, how infection spread. Entry of bacteria through synergism, fibrinoid coagulation of nutrient vessel occur that lead to decreased locally blood supply to the skin. If the blood supply decreases to the skin, the decreased tissue oxygen tension, growth of anaerobics, macroaerophilic organism occur. Then there is a production of enzyme collagenase, lecithinase, hyaluronase. Digestion of facial barrier occur. Then rapid infection of then infection rapidly spreaded. Pathonomic findings on the pathological evaluation of tissues are necrosis of superficial deep facial plane, fibrinoid coagulation of nutrient arterioles, polymorphonuclear cell infiltration, presence of microorganism within the involved tissue. air in the perineal tissue. Incidence age 30 to 60 years. Sex 10 times more common in males. Social habits more common in the male homosexual, prone to the rectal injury. Clinical features begin with the insidious onset of pruritus and discomfort of external genitalia, prodromal symptoms of fever, lethargy, which may be presented for 2 to 7 days before gangrene. The hallmark of Fournier gangrene is out of proportion pain and tenderness in the genitalia, increased genital pain and tenderness with progressive erythema of overlying skin. Dusky appearance of over the overlying skin, subcutaneous crepitation, feculent odors, obvious gangrene of a portion of genitalia, plurulent discharge from wound, a gangrenous develops pain, subside, nerve necrosis. This is the picture showing Fournier gangrene, black dusky color or inflamed necrotizing tissue. Investigations.
There is something this needs to be differentiated from. We have a nephrological unit with us alongside the urological unit. So there are lots of patients with end-stage renal disease there, and very frequently you find a necrotic glands. And very frequently we receive a call for Fournier's gangrene for that necrotic glands, and that necrotic glands is most of the time not because of Fournier's gangrene but because of calciphylaxis. There is a calcium deposition in the blood vessels, and the microvasculature usually of the penile area gets clotted off, and the glands necrosis. And that glands necrosis is because of calciphylaxis, not Fournier's gangrene. So this is something that needs to be kept in mind. Usually what we see is a small blackish area at the tip of the penis with excruciating pain in these patients. And that pain is because of ischemia that is progressing as the time goes by. And there is nothing wrong with the scrotum, the usual side of a Fournier's gangrene. So since we have lots of patients with end-stage renal disease, this has to be kept in mind that it's not always Fournier's gangrene that is leading to the necrosis. And usually that is dry gangrene because of calciphylaxis. It's dry gangrene of the penile tip, and that's wet gangrene. That's not dry gangrene.
Yes, and you have touched upon a very important topic, because these are the things which are in the ambit of urology, and we tend to just ignore all these accompaniments. For instance, one of the points that have been mentioned is that this is something Fournier's gangrene which is confined to male gender. We haven't come across, or maybe one or two cases of female gender. Otherwise, it's a male-dominated pathology. Why is it so? There have been many theories, but nothing is conclusive. The second thing is hidradenitis suppurativa. Now, this is something which is again confined to male population. I don't think I haven't seen any female coming up with the hidradenitis suppurativa. So there is kind of maybe the female hormone estrogen has got a kind of barrier against some of the dermatological diseases. Otherwise, nothing is so conclusive. And for instance, SLE, you won't find SLE in many of the male patients. You will find it more commonly in females. So there is one way or the other the pendulum swings. But the point that has been raised by Bilal is very pertinent, and we come across a lot of cases of penile tip gangrene, and that is another sort of a pathology rather than Fournier's gangrene. But what do we have to offer to these patients, like ESRD patients? It's just amputation, nothing else. Or do you think anything else?
Usually, what happens that these necrotic glances they shed off by themselves because you cannot. There's amputation that is only you can offer. And, if that dry gangrene turns into wet gangrene, then you might have to intervene surgically. Otherwise, you will have to place a suprapubic because the penis is all necrosed up and there is no space for the urine to pass through. So you have to place a suprapubic and wait for that dead area to shed off. Not much that we can do about the primary pathology of calciphylaxis and that the damage has already been done to the vessels, to the macrovasculature.
Yes. And if you ask these patients certain questions, they will tell you that the pain is electrifying pain. So whenever even a piece of cloth is just over this lesion, they feel a lot of pain. So the treatment should be as early as possible rather than late. I think so, because it leads to a lot of comorbidity with these patients who are otherwise very much burdened by the disease, that is ESRD.
Investigation. Usually patient presented with us in ER or in ward, we will go first for the complete blood count, electrolytes, RFTs, blood sugar, to see blood sugar is controlled, blood and urine culture with sensitivity, coagulation profile for DIC or ABGs, sometime if patient is that much serious. Investigation ultrasonography can be used to detect fluid or gases in the soft tissue. Sonographic hallmark presence of gas in the scrotal tissue. CT scan can detect smaller amount of soft tissue gas, define extent more specifically, identify underlying cause, small perineal abscess. MRI yields greater soft tissue details, create a logistic challenge, especially in critically ill patient. Medical treatment, restoration of normal organ perfusion, reduction of systematic toxicity, broad spectrum antibiotic to cover the anaerobics as well as aerobics, ciprofloxacin, clindamycin or metronidazole, vancomycin for MRSA tetanus prophylaxis, irrigation with superoxide water, hyperbaric therapy, IV immunoglobulin to neutralize the superantigen as streptococcus A and B, antifungal if required, non-conventional dressing with gas soaked with zinc peroxide. Surgical treatment, mostly in our setup we go a repeated aggressive debridement, serial debridement, preservation of testis, subcutaneous pocket for desiccation, reconstruction after the infection is over, fecal diversion like colostomy or ileostomy, urinary diversion at suprapubic, vacuum assisted closure. This is the picture showing here the fournier gangrene repeated debridement done. After that, we go for the surgery, reconstructive surgery. Complication of acute renal failure, ARSD, septicemia and gram-negative shock, multisystem organ failure, tetanus, death. Thank you.